Hello and welcome to this episode of Maritime Medicine in which we discuss drowning. By the end of this session, you'll be able to define drowning, identify risk factors for drowning, identify indications for cervical spine immobilization in drowning patients, and treat a patient who is a victim of drowning. The World Health Organization, as well as the World Congress on Drowning in the early 2000s, came up with a universal single definition of drowning, as there were previously over 20 different definitions, none of which agreed with each other, and most of which made it very difficult to figure out what had actually happened. So the World Health Organization definition is the process of experiencing respiratory impairment from submersion or immersion in a liquid. The idea being that there is some air-liquid interface in the airway that keeps oxygen from entering the lungs. There can be three possible outcomes. You can die from this, you can be injured, or you can have no injury. This got rid of the term near drowning, which is no longer used. This term did not make much sense because it had no real clear definition, whereas the new drowning definition makes it very clear what event happened, and then by identifying the outcome, exactly what happened to the patient in the long run. Drowning is the third leading cause of unintentional death worldwide, and it accounts for 7% of all injury-related deaths. Estimates range from about 400 to 500,000 drowning deaths a year, and these deaths occur in a bimodal distribution. So at one extreme, you have children under 4, and it's about equal male and female, and they drown in bathtubs, pools, buckets, and other liquids around the home. The second group is teenage males, and they die at a far higher rate than teenage females. And so these are the two major risk groups, although drowning can occur in any risk age group. Where does it happen? Anywhere there's water. In the home, bathtubs, buckets, toilets, outside in pools or hot tubs, ponds and canals, irrigation ditches, and anywhere there's water sports, saltwater or freshwater, drownings occur. The major risk factors are male, particularly males in their adolescence. Young children are also at risk. Alcohol is very clearly associated with drowning, accounting for almost 50% of drowning accidents in adolescent males, or at least related to those. You clearly have to have water access, failing to use PFDs, and around the home, unsupervised children. The story is almost universally, I went away for just a minute, or I just turned my head, and they were gone. The U.S. Coast Guard tracks recreational boating accident statistics. These are the 2009 statistics. They really hadn't changed much prior to this. They record almost 5,000 accidents with 736 fatalities. Of those, 76% died of drowning. 84% of those people were not wearing PFDs, and 70% were in boats less than 21 feet. There were almost 4,000 injuries, 3,358, and $36 million in damages. So this is not inconsequential. The fatalities also tend to be seasonal, and this relates to cold shock and cold incapacitation, topics covered in other sessions. So when the water's colder, people who have accidents are much more likely to have fatal accidents. There's a classic image of going down 3 times, the person waving their arm and screaming, struggling, and then disappearing under the water. The reality is that most of the time, drowning is a silent event. And until someone does a head count, nobody notices that the individual is missing. They just quietly slip under the water. So what happens when you drown? This is a chest x-ray. The lungs are those 2 darker areas, and the white patchiness throughout the lungs are what we're concerned about. There's differences in the osmotic pressures in various fluids. So your plasma has about 0.9% normal saline, salt water about 5%, In freshwater, less than 0.1%. So because of those osmotic differences, water or electrolytes will tend to move across membranes. Salt water also has other electrolytes, calcium and magnesium, potassium, so these also affect osmotic pressures. In theory, in a saltwater drowning, salt water is aspirated into the lungs, and because it has such a high sodium level, water gets sucked into the alveoli from the pulmonary capillary plasma. The alveoli fill up, and the patient dies from pulmonary edema. In addition, because there's so much calcium and magnesium in that salt water, that gets absorbed the other direction into the bloodstream, and those high levels of calcium and magnesium cause the heart to go into an irregular rhythm and cause death. In freshwater, the theory is people aspirate fresh water, and because there's much more salt in the bloodstream, that water gets sucked into the pulmonary circulation. And because so much water comes rushing into the bloodstream, the red blood cells explode. That's called hemolysis. And potassium is released, and very high potassium levels result in cardiac arrest. What's the reality? People die of pretty much simple asphyxiation. And what that means is that your airway is sort of a self-protecting structure. Your vocal cords will go into spasm to keep foreign bodies and fluids from going in. If you've ever had water kind of go down the wrong way and splash into your throat and you cough and then all of a sudden you can't breathe, that's laryngospasm. And eventually that laryngospasm relaxes and you can breathe again. But if you get continuous stimulation from, say, water in the airway lapping against the vocal cords, the laryngospasm can be persistent to the point where you pass out or even die from asphyxiation, the same as if a pillow had been held over your face. And then, as your body relaxes, the laryngospasm finally breaks and water trickles into the lungs passively. Because of this, basic life support, airway, and ventilation can be highly effective in resuscitating these patients. And in fact, a patient in the water who's a drowning victim should have rescue breaths given in the water, because more often than not, the reason why they're in respiratory or cardiac arrest is from the drowning, and if you can reverse the respiratory arrest, you can reverse the cardiac arrest. Now, some water does go in, and that does lead to problems. You get hypoxia from asphyxiation. The water itself can smother you. Your alveoli are covered with a thin detergent called surfactant. Your body makes it. And if you've ever done a dive off a diving board and mistimed it and done a belly flop, you feel like you landed on concrete. That's the surface tension of water. Well, your alveoli are lined with water as well. There's a lot of moisture, high humidity in the lungs. And that water tends to make the alveoli collapse shut. And that water tension can be so high that the alveoli really can't be reopened easily. It takes a lot of pressure to reopen them. So you have this stuff called surfactant, which is pretty much like a detergent, and it breaks up the water tension and lets the alveoli stay open at very low pressures. If you wash that alveoli out, the surfactant out of the alveoli will all collapse and they won't be able to be reopened easily. And then again, those electrolyte abnormalities, which are probably more theoretical than real. You can also inhale other stuff depending on what you're in. And any junk that gets in your lung is going to be an irritant to the lung and a source of infection. So an irritated lung goes into a state called acute respiratory distress syndrome or adult respiratory distress syndrome, but ARDS. Different names, same process. So here's a patient who was a drowning victim, and this is their chest x-ray 30 minutes after the event. And you look and you see the black air spaces of the lungs on both sides. They look open. You're not seeing a lot of haziness or fuzziness. There may be a little bit up in the right upper chest, and remember, as you're looking at a chest x-ray, the patient's right is to the left side of the screen, the patient's left is to the right side. So there maybe is a little bit of haziness up there, but nothing that's really overwhelmingly remarkable. At 120 minutes, the patient has a breathing tube in. That's that white line running from the head down into the chest, down the midline there, and you're starting to see all this patchy haziness. They're in respiratory failure. They're having significant trouble breathing because their lungs are filling up with fluid, and it's harder and harder to ventilate them. And then at 480 minutes, the lungs are almost completely whited out. So all the surfactant has been washed out, the lungs are collapsing, there's fluid in the lungs. Even with a breathing tube in, even on high flow oxygen, it is almost impossible to oxygenate a patient whose lungs look like this. So the most important thing to do is to prevent drowning. And in almost any circumstance, personal flotation devices are critically important. They will radically improve your chances of survival. You can engineer protections in, so fences around swimming pools, unsinkable boats, things along those lines. Learn to swim programs for kids are useful as long as they don't give kids too much confidence, or perhaps more importantly, parents too much confidence that they don't have to supervise their kids. The kids still need to be supervised, but these programs give children the ability to reach the edge of a pool or the edge of a body of water on their own if they fall in. And no alcohol and water mixers. They don't go together. They result in drowning. So how do you treat this? The first thing is scene safety. If you're not trained and equipped to retrieve a drowning patient from the water, don't go in the water. PFDs, appropriate training, particularly in fast-moving, swift water situations or large wave situations. If you don't know what you're doing when you get in the water, you're going to end up a victim just as much as that original patient, and then you're going to have to be rescued as well, and that basically just pisses off all of the other people that you're working with, so don't do it. If you have a patient and they're not in cardiac arrest, they're not in respiratory arrest, control any exsanguinating hemorrhage, manage the airway, breathe for them if need be, assess their circulatory status and neurologic status, expose them, get rid of their wet clothes, rewarm them to normothermia, find any clues as to what happened, and if they're at all symptomatic, put them on oxygen. If they're having a lot of trouble breathing, positive pressure ventilation with a bag valve mask. If you have continuous positive airway pressure or CPAP available to you, put that on the patient. That helps to keep the alveoli open, so even if the surfactant's washed out, they won't collapse down so much. Remove the patient's wet clothes and try to rewarm them to a normothermic state. Start an IV and discuss evacuation with medical control. They may only have mild symptoms now, but remember that chest x-ray. By 2 hours and then by 8 hours, their respiratory status, their lung status was a nightmare, and you do not want to try to manage that shipboard. You can also get delayed presentation of lung injury up to 72 hours later. So if there's any question of a significant submersion event and you think the patient aspirated water, so it's going to have a lung injury, evacuate them early. You don't want to wait 3 days and suddenly have them get really, really sick on you. That's no good. If they are in cardiac arrest, we do CPR, but we don't do CAB. We do ABC because the primary insult is that respiratory failure, and patients will recover often just with ventilation. So again, if they're in the water and you can provide rescue breaths for them with a pocket mask, do it. You may turn around a cardiac arrest or a respiratory arrest just with your rescue breathing. If they're in cold water, so less than 70 degrees Fahrenheit or 21 degrees Celsius, plan for prolonged resuscitation, hours, 2 hours potentially. Talk to medical control about it, but if they seem to be responding, continue your resuscitation. And even in warmer water than that, there have been patients who've been resuscitated after prolonged periods with complete neurologic recovery. So talk to medical control about your best management strategy. And if they have return of spontaneous circulation or ROSC, ROSC, evacuate them. Now, I haven't mentioned cervical spine immobilization, and this used to be a hammered-on mantra of drowning, which was always assume a cervical spine injury. Now, cervical spine immobilization, as has been discussed elsewhere, is potentially harmful to patients. Spine board immobilization is potentially harmful to patients. It certainly makes it difficult to manage an airway and resuscitate the patient. And so some people who thought maybe it wasn't the best choice did some studies and found that cervical spine injuries were relevant in less than 1 in 10,000 drowning events. So they were related to less than 1 in 10,000 drowning events. And so the conclusion is, unless there's a specific reason, the patient was in a car that was in an accident and went off into the water, or they were in a boat that capsized, or it was a diving accident, they dove into shallow water and then floated to the surface unresponsive, unless you have a very specific reason to think they had a cervical spine injury, it's less than 1 in 10,000 chance there is one, and immobilizing the cervical spine will do more harm than good by interfering with your resuscitation. Please complete any associated knowledge reviews, and if you have any questions, don't hesitate to contact your professor or instructor. Thank you very much.